Okay, this is chapter 14 of the Mental Health ATI, bipolar disorders. If my recordings have helped you at all, do me a favor and share this with a couple of your classmates or something. Maybe that can help them too, so that would be greatly appreciated. So bipolar disorders are mood disorders with recurrent episodes of depression and mania. Bipolar disorders usually emerge in early adulthood, but early onset bipolar disorder can be diagnosed in pediatric clients. Because manifestations can mimic expected findings of attention deficit hyperactive disorder, which is ADHD, it is more difficult to assess and diagnose bipolar disorders in children than in other client age groups. Periods of normal functioning alternate with periods of illness, though some clients are not able to maintain full occupational and social functioning. Clients can exhibit psychotic, paranoid, and/or bizarre behavior during periods of mania. Client care. Care of a client who has bipolar disorder will mirror the phase of the disease that the client is experiencing. Acute phase, which is hospitalization, can be required. Reduction of mania and the client's safety are the goals of treatment. Risk of harm to self or others is determined. One-to-one supervision can be indicated for client safety. Continuation phase. Treatment is generally 4 to 9 months in duration. Relapse prevention through education, medication, adherence, and psychotherapy is the goal of treatment. Maintenance phase. Treatments generally continues throughout the client's lifetime. Prevention of future manic episodes is the goal of treatment. Behavior shown with bipolar disorders. Mania. An abnormally elevated mood, which can also be described as expansive or irritable, usually requires hospitalization. Manic episodes last at least 1 week. Hypomania, a less severe episode of mania that lasts at least 4 days, accompanied by 3 or more manifestations of mania. Hospitalization is not required, and the client who has hypomania is less impaired. Hypomania can progress to mania. Rapid cycling, 4 or more episodes of hypomania or acute mania within 1 year and associated with increased reoccurrence rate and resistance to treatment. Types of bipolar disorders. Bipolar 1 disorder. The client has at least 1 episode of mania alternating with major depression. Bipolar 2 disorder. The client has 1 or more hypomanic episodes alternating with major depressive episodes. Cyclothymic disorder. The client has at least 2 years of repeated hypomanic manifestations that do not meet the criteria for hypomanic episodes, alternating with minor depressive episodes. Comorbidities. Oh my God, this is a long one. Substance use disorder, anxiety disorders, borderline personality disorder, oppositional defiant disorder, social phobia and specific phobias, migraines and metabolic syndrome. Risk factors, genetics, having an immediate family member who has a bipolar disorder. Psychological, neurobiologic and neuroendocrine disorders. Environmental, increased stress in the environment can trigger mania and depression and increase risk for severe manifestations in genetically susceptible children. Relapse, use of substances such as alcohol, cocaine, and caffeine can lead to an episode of mania. Sleep disturbances can come before, be associated with, or be brought on by the episode of mania. Psychological stressors can trigger an episode of mania. Oh my goodness. Expected findings, manic characteristics, libel mood with euphoria, restlessness, impulsivity, demanding and manipulative behavior, poor judgment, impairment in social and occupational functioning, decreased sleep, denial of illness. Depressive characteristics, flat, blunted libel effect, tearfulness, crying, lack of energy, difficulty concentrating, self-destructive behavior, psychomotor retardation or agitation. Standardized screening tool is the Altman Self-Rating Mania Scale, or ASRM, a standardized tool that assesses the client's placement on the continuum for depression to mania and is useful for the management and treatment of the client. Nursing care. The care of the client is based on the phase of bipolar disorder that the client is experiencing. Nursing care is provided throughout this process. Acute manic episode. Focus is on safety and maintaining physical health. Therapeutic milieu within acute care mental health facility. Provides a safe environment during the acute phase, assesses the client regularly, decreases stimulation, be aware of noise, music, TV, and other clients. In certain cases, seclusion might be the only way to safely decrease stimulation for the client. Follow agency protocols, implement frequent rest periods, protect client from poor judgment, monitoring sleep, fluid intake and nutrition, supervising choice of clothes, giving step-by-step reminders for hygiene and dress, use a calm, matter-of-fact specific approach, give concise explanations, avoid power struggles, listen to and act on legitimate client grievances, and use therapeutic communication techniques. Therapeutic procedures. Electroconvulsive therapy, or ECT, can be used to moderate extreme manic behavior, especially when pharmacological therapy, such as lithium, has not worked. Clients who are suicidal or those who have rapid cycling can also benefit from ECT. Complications. Physical exhaustion and possible death. A client in a true manic state usually will not stop moving and does not eat, drink, or sleep. This can become a medical emergency. Nursing actions. Prevent client self-harm, decrease client's physical activity, ensure adequate food intake, promote an adequate amount of sleep, manage medication appropriately. Client education. Case management to provide follow-up for the client and family, group family and individual psychotherapy to improve problem solving and interpersonal skills. Health teaching, the chronicity of the disorder requiring long-term pharmacological and psychological support, benefits of psychotherapy and support groups to prevent relapse, indications of impending relapse and ways to manage the crisis, medication administration and adherence. Mood stabilizers, lithium. Purpose, expected pharmacological action. Lithium produces neurochemical changes in the brain, including serotonin receptor blockade. There is evidence that lithium decreases neuronal atrophy and or increases neuronal growth. Therapeutics. Lithium is used to the treatment of bipolar disorders. Lithium controls episodes of acute mania, helps to prevent the return of mania, and decreases the incidence of suicide. Complications. Some adverse effects resolve within a few weeks of starting the medication. GI distress. Nausea, diarrhea, abdominal pain. Nursing actions. Advise the client that the GI distress is usually transient. Administer medication with meals or milk. Find hand tremors can interfere with purposeful motor skills and can be exacerbated by factors such as stress and caffeine. Nursing actions. Administer beta-adrenergic blocking agents, propranolol. Adjust dosage to be as low as possible, given divided doses, or use long-acting formulations. Advise the client to report an increase in tremors, which could be a manifestation of lithium toxicity. Polyuria and mild thirst. Use a potassium-sparing diuretic, such as spirulactone. Maintain adequate fluid intake by consuming at least 1.5 to 3 liters of fluid a day from beverages and food sources. Weight gain. Assist the client to follow a healthy diet and regular exercise regimen. Renal toxicity. Monitor INO, adjust dosage and keep the dose at the lowest level. Assess baseline BUN and creatinine and monitor kidney function. Goiter and hypothyroidism. With long-term treatment, obtain a baseline thyroid TSH levels prior to starting treatment, and then annually administer levothyroxine. Monitor for indications of hypothyroidism, cold, dry skin, decreased heart rate, and rate gain. Brady dysrhythmias, hypotension, and electrolyte imbalances. Maintain adequate fluid and sodium intake. Lithium toxicity. Lithium levels is less than 1.5. Manifestations is diarrhea, nausea, vomiting, thirst, polyuria, muscle weakness, and fine hand tremors. Nursing actions. Instruct the client that the manifestations at low levels often improve over time. Early indications of lithium toxicity. Lithium level is 1.5 to 2. Manifestations is mental confusion, sedation, poor coordination, coarse tremors, and ongoing GI distress. Nursing actions. Instruct the client to withhold the medication and notify the provider. Administer new dosage based on blood lithium and sodium levels. Excretion can need to be promoted. Advanced indications. Lithium level is 2.0 to 2.5. The manifestations is extreme polyuria of dilute urine, tinnitus, giddiness, jerking movements, blurred vision, ataxia, seizures. Administer an emetic to alert clients or administer gastric lavage. Urea, mannitol, or aminophylline may be prescribed to increase the rate of excretion. Severe toxicity. Lithium level is greater than 2.5. Manifestations is rapid progression of manifestations leading to coma and death. Nursing actions as hemodialysis can be warranted. Contraindications. Lithium is a pregnancy risk category D medication. It is considered teratogenic, especially during the first trimester of pregnancy. Discourage clients from breastfeeding if lithium therapy is necessary. Lithium is contraindicated in clients who have severe renal or cardiac disease, hypovolemia, and schizophrenia. Use cautiously in older adult clients and clients who have thyroid disease, seizure disorder, and diabetes. Interactions as diuretics. Sodium is excreted with the use of diuretics. With decreased blood sodium, lithium excretion is decreased, which can lead to toxicity. Monitor for indications of toxicity. Observe for indications of toxicity and notify the provider. Maintain a diet adequate in sodium and drink 1.5 to 3 liters of water. NSAIDs. Concurrent use increases renal reabsorption of lithium, leading to toxicity. Avoid use of NSAIDs to prevent toxic accumulation of lithium. Use aspirin as a mild analgesic as it does not lead to toxicity. Anticholinergics such as antihistamines and TCAs. Abdominal discomfort can result from anticholinergic-induced urinary retention and polyuria. Avoid medications that have anticholinergic effects. Nursing administration. Monitor plasma lithium levels while undergoing treatment. At initiation of treatment, monitor levels every 2 to 3 days until stable and then every 1 to 3 months. Closely monitor levels after any dosage change. Lithium blood levels should be obtained in the morning 10 to 12 hours after last dose. During initial treatment of the manic episode, higher levels can be required. Maintenance level range is 0.6 to 1.2. Older adult clients are at an increased risk for toxicity and require more frequent monitoring of blood lithium levels. Care for a client who has advanced or severe lithium toxicity should take place in an acute care setting with supportive measures provided. Hemodialysis can be indicated. Advise the client that effects begin within 5 to 7 days. Maximum benefits might not be seen for 2 to 3 weeks. Advise the client to take lithium as prescribed. This medication must be administered in 2 to 3 doses daily. Due to a short half-life, taking lithium with food will help decrease GI distress. Encourage the client to adhere to laboratory appointments needed to monitor lithium effectiveness and adverse effects. Emphasize the risk of toxicity is high due to the narrow therapeutic range. Provide nutritional counseling. Stress the importance of adequate fluid and sodium intake. Instruct the client to monitor for indications of toxicity and when to contact the provider. Mood-stabilizing anti-epileptic medications. Carbamazepine, valproate, and lamotrigine. The purpose: anti-epileptic medications help treat and manage bipolar disorder through various mechanisms, slowing the entrance of sodium and calcium back into the neuron, thus extending the time it takes for the nerve to return to its active state. Potentiating the inhibitory effects of gamma butyric acid, which is GABA. Inhibiting glutamic acid, which is glutamate, which in turn suppresses central nervous system excitation. Therapeutic uses. These medications are used to treat and prevent relapse of manic and depressive episodes. They are particularly useful for clients who have mixed mania and rapid cycling bipolar disorders. Complications. Carbamazepine, the minimal effect on cognitive function. CNS effects, nystagmus, double vision, vertigo, staggering gait, and headache. Nursing actions. Administer in low doses initially and then gradually increase dosage. Administer dose at bedtime. Blood dyscrasias, leukopenia, anemia, and thrombocytopenia. Obtain baseline CBC and platelets. Perform ongoing monitoring of these. Observe for indications of thrombocytopenia, including bruising and bleeding of gums. Monitor for indications of infection like fever or lethargy. The client education is notify the provider of indications of blood dyscrasias are present. Heterogenesis, avoid use in pregnancy. Hypoosmolarity, promotes secretion of antidiuretic hormone, which inhibits water excretion by the kidneys and places the client who has heart failure at risk for fluid overload. Nursing actions, monitor blood sodium, monitor for edema, decrease in urine output, and hypertension. Skin disorders includes dermatitis, rash, and Stevens-Johnson syndrome. Nursing actions, treat mild reactions with anti-inflammatory or antihistamine medications. Client education, withhold the medication and notify the provider if Stevens-Johnson syndrome occurs. Wear sunscreen to reduce chance of skin disorders. Lamotrigine, double or blurred vision, dizziness, headache, nausea, and vomiting. The client education is avoid performing activities that require concentration or visual acuity. Serious skin rashes include Stevens-Johnson syndrome. Client education is withhold the medicine and notify the provider if a rash occurs. To minimize risk of serious rash, start with a low dose and slowly increase it. Valproate, GI effects, nausea, vomiting, and indigestion. Client education. These effects are generally self-limiting. Take medication with food or switch to enteric-coated formulations. Hepatotoxicity, evidenced by anorexia, nausea, vomiting, fatigue, abdominal pain, and jaundice. The nursing actions is assess baseline liver function and monitor liver function regularly, minimum of every 2 months during the first 6 months of treatment. Avoid using in children younger than 2 and administer the lowest effective dose. Client education. Observe for indications of hepatotoxicity and notify the provider immediately if they occur. Pancreatitis, evidenced by nausea, vomiting, and abdominal pain. The nursing actions are monitor amylase levels and discontinue the medication if pancreatitis develops. Client education. Observe for manifestations of pancreatitis and notify the provider immediately if they occur. Thrombocytopenia, nursing actions. Monitor platelet counts. Client education. Observe for indications such as bruising and notify the provider if these occur. Heterogenesis. Client education. Avoid use during pregnancy. If considering pregnancy, discuss other treatment options with the provider. Weight gain. Client education. Follow a healthy diet and regular exercise regimen. Contraindications. These medications are pregnancy risk category D medications. They can result in birth defects. Carbamazepine is contraindicated in clients who have bone marrow suppression or bleeding disorders. Monitor plasma levels of valproate and carbamazepine while undergoing treatment. The therapeutic blood level range for carbamazepine is 4 to 12. The therapeutic blood level range for valpuric acid is 50 to 120. Lamotrigine needs to be slowly titrated to prevent adverse effects. Interactions, carbamazepine, oral contraceptives, and warfarin. Concurrent use of carbamazepine causes a decrease in the effects of these medications due to stimulation of hepatic and drug metabolizing enzymes. Nursing actions. Monitor for therapeutic effects of warfarin. Dosage can need to be adjusted. Client education. Use an alternate form of birth control. Grapefruit juice inhibits metabolism of carbamazepine, therefore increasing blood levels of the medication. Client education. Avoid intake of grapefruit juice. Concurrent use of other anticonvulsants decreases the effects of carbamazepine by stimulating metabolism. Nursing actions. Monitor carbamazepine levels and adjust dosages as prescribed. Lamotrigine. Carbamazepine, phenytoin, and phenobarbital is concurrent use decrease the effects of lamotrigine. Nursing actions. Monitor for therapeutic effects and adjust dosages as prescribed. Concurrent use of valproate inhibits drug metabolizing enzymes, thereby increasing the half-life of lamotrigine. Nursing actions. Monitor for adverse effects and adjust dosages as prescribed. Concurrent use of oral contraceptives decreases the effectiveness of both medications. Client education. Use an alternate form of birth control. Valproate. Concurrent use of other anticonvulsants affects blood levels of valproate. Nursing action. Monitor valproate levels and adjust dosages as prescribed. Nursing evaluation of medication effectiveness. Depending on the therapeutic intent, effectiveness can be evidenced by the following: relief of acute manic manifestations or depressive manifestations, verbalization of improvement in mood, ability to perform ADLs, improved sleeping and eating habits, and appropriate interaction with peers. Antipsychotics. Lurasidone, olanzapine, and quetiapine aripiprazole, risperidone, acenapine, cariprazine, and ziprasidone are useful during acute mania with or without valproic or lithium. Zisperazone, olanzapine, and ariprazole can be used long-term as a prophylaxis against mood episodes. Lurasidone is approved for bipolar depression. Okay, a nurse is discussing relapse prevention with a client who has bipolar disorder. Which of the following information should the nurse include in the teaching? Difficulty sleeping can indicate relapse. Participating in psychotherapy can help prevent a relapse, and anhedonia is a clinical manifestation of depressive relapse. A nurse is planning care for a client who has bipolar disorder and is experiencing a manic episode. Decide which intervention should be included and which shouldn't. Offer concise explanations, establish consistent limits, and use a firm approach with communication. A nurse is admitting a client who has a new diagnosis of bipolar disorder and is scheduled to begin lithium therapy. When collecting a medical history from the client's caregiver, which of the following statements is the priority to report to the provider? Concurrent medications include furosemide and congestive heart failure. A nurse is discussing routine follow-up needs with a client who has a new prescription for valproate. The nurse should inform the client of the need for routine monitoring of which of the following? AST, ALT, and LDH.